Thanks, Colin, and thanks to the organizers for inviting me to speak today about pulmonary hypertension. It's about time that you recognize that the right ventricle is more important than the left ventricle. As you can notice, they specifically put me at the end of the day between you and the bottle of wine to cause your atrial fibrillation. So we'll try and get through this, and we'll have some time at the end for some questions. I was asked to talk about some of the newest strategies for pulmonary hypertension, and we'll go over it. I do have some disclosures. We have several research grants that we get funded for certain of the therapies, some consulting and speaker training. So we are at Cottage, one of the first of the accredited centers for pulmonary hypertension. And in fact, many of you in this room, and all of you who know who you are, were instrumental to getting this accreditation over the last several years. This accreditation has provided us a platform for the standard of care of how we treat pulmonary hypertension in this country. So what I was going to touch on today were several things. It's not new strategies, but I guess the hot potato strategies for pulmonary hypertension. First, what we'll do is we'll touch on some of the updates that have come in terms of the definition. I briefly touch on some of the treatment goals, how we do a risk assessment, and then I'm going to dive into the actual therapeutic options, which has changed dramatically even over the last few months. We're going to talk a little bit about some of the paradigm shift to how we manage combination therapy, and I'm going to review some of the pivotal data that we have on that. And then lastly, I was going to briefly touch on some of the clinical trials and future where we are with pulmonary hypertension. One of the big changes that occurred at the end of 2018 was the definition for pulmonary hypertension has changed from the NICE, the World Symposium of Pulmonary Hypertension, with a mean PA pressure now greater than 20. It used to be 25. All the clinical trials we've done up to date have really used 25. But they've maintained, and we have still maintained, the pulmonary vascular resistance of more than 3 Wood units. So what does this really mean in essence? It really helps potentially looking for patients who are early in disease for screening, such as high-risk populations, scleroderma patients, etc. It hasn't really altered the way we actually treat patients, but I just wanted you to be aware of this new update and definition. When we look at pulmonary hypertension patients, as you recognize, this is somewhat of an orphan disease, and we really ultimately would like to improve survival. Unfortunately, many times we are not able to do that, and it's certainly one of the most important goals that we strive for with therapies. We try and improve quality of life. We look at exercise capacity. We want patients to try and improve that. That's a big part of their quality of life. And ultimately, as physicians and as caretakers, we want to try and improve the hemodynamics because we believe this disease has a major impact on the right ventricle. Patients would say to you that they want to have less symptoms, less shortness of breath, and importantly, reduce hospitalization, lung transplant, and death. So let's talk about the rationale for sequential combination therapy. I put the slide in because we have a bunch of cardiologists, and I'm the only pulmonologist invited to a cardiology conference. So I had to dumb it down a little bit so they understand what we're talking about in terms of the types of pulmonary hypertension that we look for. So we have 5 groups of pulmonary hypertension. The group 1 is the pulmonary arterial disease, the disease that really is involving the pulmonary vasculature with an effect that causes significant stress and pressure on the right ventricle. But that is a very small part of pulmonary hypertension. The majority of it, as cardiology in the world will be dealing with, is group 2 disease, PH due to left heart disease by far more common. In my world, in the lung world, pulmonary hypertension from COPD and interstitial lung disease, or the hypoxemia groups, we now have a significant problem with pulmonary thromboembolic disease and trying to recognize that as group 4, and then the mixed group. So we're going to focus most of the data that I'm going to be talking about today is really on that group 1 disease, those that have either idiopathic or hereditary pulmonary hypertension or associated pulmonary hypertension, things, for example, as methamphetamine related and anorexic use related pulmonary hypertension, scleroderma, and HIV-related pulmonary hypertension. There's several others, but those are the big ones that we're going to look at. The biggest problem is that even when you look at different decades of therapy that we've had for pulmonary hypertension, which started around 1996, you can see that although in the year over 2000, which is in the red line, our survival rates have clearly improved over 20 years, but we still have significant mortality. Those that remain an annual mortality rate of 15% despite the advent of these new therapies. And the main reason that patients die from this disease is the right ventricular failure. So one of the roles that we have moved towards is to try and do better risk stratification, is to try and understand which are the higher risk individuals and where we need to focus higher and more concentrated therapies and try to ultimately move patients from intermediate and high risk to low risk. And we've based it really on 4 major categories. We've based it on clinical symptoms of right heart failure and progressive symptoms. We try and evaluate patients from a functional capacity using things like the 6-minute walk test. We do quite a bit of cardiopulmonary exercise testing with some very good data now looking at the VE/VCO2 slope at anaerobic threshold as a way to predict a response of the right ventricle to therapeutic improvements. We look at certain biomarkers such as the NT-proBNP, and we rely heavily on the imaging, cardiac imaging. And then ultimately, we look at the hemodynamics to see if there's been improvement in patients that are high-risk hemodynamics. We need to jump on and get them treated. So when you look at the importance of these risk stratification, there are several registries in the country. The COMPRA registry, which is the German registry, the French registry, the Swedish registry, all have clearly show that those patients that get move into the low risk category have a much better survival rate. And when you look at the data from the United States, which is the REVEAL registry, we have shown that those patients that we can get into the low risk have a significantly improved survival compared to those that don't. The problem is that in the United States, and at least in the REVEAL registry, only 29% of patients ever get to the low risk category. The others remain in either high risk or moderate risk. So it's important that we as a group keep working and try to get patients to that low risk category. I'm not going to really have much time to talk about all the treatment options, but I do want to emphasize some of the general measures and supportive therapies that are as important as the targeted specific therapies that we have for pulmonary hypertension. Many times patients fail therapy because they haven't done the general measures or the supportive therapies, including avoidance of pregnancy, vaccinations, supervised exercise, oxygen, use of control of the systemic blood pressure, arrhythmia control. I did put a note in here about oral anticoagulation because this is a moving target. When I first started doing pulmonary hypertension, everyone got anticoagulation across the board. It was pretty standard. But we've shown that in patients who, for example, have scleroderma-associated pulmonary hypertension, data from the COMPRA registry showed that there was no survival benefit and, in fact, higher complication rates from GI bleeding in the scleroderma group of patients on anticoagulation. So bottom line, you need to have a case-by-case basis on that. So let's dive into the current therapies. The current therapies we have are really broken into 3 main targets. One of the targets is the endothelin receptors. Endothelin is a very powerful vasoconstrictor. It's abnormally elevated in patients who have pulmonary arterial hypertension, and using medications such as the endothelin receptor antagonists block the receptor and therefore block the effects of it. By doing so, the hope is that you lead to vasodilatation and some antifibrotic effects. The nitric oxide pathway, one of the older pathways and well-known pathways, patients who have pulmonary arterial hypertension often have nitric oxide deficiencies. They have abnormalities with nitric oxide synthetase. And we have medications now that can either directly stimulate cyclic GMP through things like soluble guanylate cyclase, and we also have mechanisms such as the PDE5 inhibitors to try and block PDE5, which leads to higher levels of cyclic GMP, which is the active second messenger that causes vasodilatation and the remodeling process. The prostacyclin pathway, also a very powerful pathway through the arachidonic acid, again, is abnormal in patients who have pulmonary arterial hypertension. They have low levels of prostacyclin synthetase, so providing analogs or exogenous prostacyclin or direct stimulation of the IP receptors now we have available can actually lead to vasodilatation through a second messenger of cyclic AMP. So what's important really here is the strategy is not so much that we are finding new pathways, but it's really what kind of combinations we can use with these existing three pathways and which ones should we be using and which ones we shouldn't be. So I think that the way I look at it and the way that most of us in the field now are looking at it is do the risk assessment, decide on the severity of where you are going to be doing this, and then either do some of the initial monotherapy or sequential add-on therapy, or do we do upfront combination therapy? And a lot of the clinical trials we're doing now are trying to answer this particular question. And then one last issue is, do we consider switching therapies if people are not doing well in one particular class? And there has been a tremendous shift in the way we do clinical trials in pulmonary hypertension. And yeah, when you look at the slide on the left side, when you see N of numbers, yeah, this is not cardiology where we have 15,000 patients in clinical trials. Intravenous epoprostenol got approved in this country with 84 patients. So just to give you some idea, there's very small numbers, so it's hard to do very robust clinical trials in this. However, in the last decade, we have now moved from doing these much smaller studies of 16, 18-week studies to now morbidity and mortality studies. And in fact, our center was one of the first centers that were involved in the SERAPHIN study to get that product MACITENTAN to market based on several of our patients that were enrolled in that study. This is just a sort of a timeline, and you can see, and the purpose of the slide is to show that those studies that were done in black, those were monotherapy studies against placebo. We no longer can do that. We no longer have clinical equipoise to say that we can put patients on placebo and put them in clinical trials. So most patients are put on a background therapy. So the red names are studies that essentially patients are on background therapy and then they get add-on therapy in a randomized fashion. There were really only two upfront combination studies, and the one that I want to mention is the AMBITION study, which was upfront combination of ambrisentan and tadalafil versus monotherapy in each of the arms, and was a very landmark study for us in the field that has really pushed the envelope on, or at least pushed us to understand that upfront combination has an advantage. The upfront combination, as I say, is an evolving paradigm and clearly is the right thing, and the majority of us now are using this for initial therapy. So taking this is from the 6th World Symposium, and I'm going to highlight the area in red just to bring it a little bit bigger. Essentially, patients who are treatment naive, the guidelines now are recommending that these patients have a confirmed diagnosis at an expert center. I think that was one of the big things that they put in the symposium. Those that are vasoreactive, which is a very small percentage, less than 5 to 10% of patients have a true vasoreactive response, would be candidates for calcium channel blocker therapy. But I want to emphasize, it's only for those that are truly vasodilator responsive, meaning that you've dropped the mean PA pressure by less than 40 millimeters, by at least 10 millimeters, and that the cardiac output has actually gone up. Because use of calcium channel blockers in non-responders is not only unhelpful, it can be extremely detrimental, especially to the right ventricle. The right ventricle doesn't deal with negative inotropy at all well. So it's important that calcium channel blockers are only used in a rare group of patients with pulmonary hypertension. So the majority of patients fall into that category of non-vasoreactive. So the question is, are they low or intermediate risk, high risk? Clearly, the high-risk patients need to be put on parenteral intravenous therapies. It's the low or intermediate risk, do we do initial monotherapy or initial oral combination? So let me just put my feelings about what I think the role for monotherapy, which has dwindled over the year, and that is those that are extremely low risk, who are either on an acute vasoresponder on calcium channel blockers. Maybe we should be considering therapy for those on just monotherapy. Those that have historically been on monotherapy, who have been part of the clinical trials for years, who are doing well, why do we now want to add additional therapy necessarily? The bigger group, I think, are the older patients, those that have risk factors for heart failure, preserved ejection, those that have medication intolerability, polypharmacy, and then anytime there's a concern for pulmonary vein occlusive disease, we be careful when adding therapies because you can certainly worsen pulmonary edema. Those that have very mild hemodynamics, and many of the patients with HIV and portal pulmonary hypertension were actually excluded from many of these randomized clinical trials. And we don't know the answer, should those patients necessarily be just treated on monotherapy. And in many places, combination therapy is unavailable or contraindicated. So I do caution this. If you are going to try a monotherapy on a therapy like a sildenafil or a single drug, those patients need to be reassessed within 3 months. The effect of these medications from data from the French registry shows that you're going to get the maximum bang for your buck after 3 months. So if you are still a high or intermediate risk at 3 months on monotherapy, that's inadequate therapy and you should be escalating treatment. So looking at those that are already on therapy, again, risk stratification and then the addition of specific therapies. So this was, for example, patients who are already on a background ERA or a PDE5 recommendation from the World Health Symposium, for example, here giving a grade 1 recommendation for the addition now of SELEXIPAG, which is an IP receptor agonist. But again, maximal medical therapy is still considered maximal only once you have failed intravenous therapy. So if patients are remaining high risk on the oral therapies, you really want to be moving them onto intravenous or subcutaneous therapies. Some of the basic principles that we follow when we do combination therapies in this group of patients. One of them is the fact that you want to avoid within-class combinations. So you wouldn't be putting patients on 2 ERAs, like ambrisentan, bosentan, or macitentan. You wouldn't put them on both. You're just going to create higher side effects with no real added efficacy. We know from some of this phase 2 study data on riociguat, which is a soluble guanylate cyclase in the nitric oxide pathway, that when it's used in combination with PDE5s can cause quite a life-threatening hypotension. So we avoid that combination. And then we know that the IP receptors, like SELEXIPAG, should not be used in combination with other prostacyclines. So really, when you get to the bottom line of this, with this limited data, the only source of knowledge is experience. So just to give you a little bit of data on the so-called triple sequential combination therapy, if you look at the landmark studies that we have right now in pulmonary hypertension, all of those that were on pre-existing background therapy, this is the SERAPHIN study showing MACITENTAN, when it's added to that placebo. Now that placebo line, on the third line, is actually patients who are on background sildenafil. So that placebo is all patients that were on background therapy. You can still see that you got a robust response by adding the therapy macitentan. And this is for the GRIPHON study. This was when SELEXIPAG was added to background therapy. And in this group, 47% of the patients were actually on background ERA and a PDE5. That by adding this, by adding it, you got improvement even if they were on background therapy. Obviously, one of the big issues we deal with is the side effects, because the more medications you have, the harder it is to deal with the side effects. And you can see that in this study in the GRIPHON, that 76% of patients experience severe headache, 55% with diarrheas. And these are things that you have to manage when you're in the office and in the clinic. So just because we have limited time, I did want to mention the Ambition. The Ambition was the first of its kind where we did an upfront combination of ambrisentan and tadalafil, comparing it to each individual arm of ambrisentan or tadalafil, again in group 1 patients. So it was quite a big study for us. 500 patients for us is a big study. And essentially, for the purpose of time here, I'll just show you the data that those that were in the upfront combination had a significant reduction to the time to first clinical failure, which was for us an important thing. What drove that time to first clinical failure was the reduction in hospitalizations. So from a payer mix standpoint, this was very powerful for them, and it has led to pretty much the standard now that newly diagnosed patients with pulmonary hypertension will often get upfront combination ERA PD5 that are in the low or intermediate risk group. Again, the side effect profile is a challenge. You've got to anticipate the peripheral edema, the headache, and you've got to warn and counsel the patients. And we have in our clinic, we have a mechanism to be able to deal with these side effects as we anticipate. So I guess the big one, the upfront triple combination, coming towards the end. So a triple axle is a beautiful thing to watch. You know, when performed perfectly well, executed well, it really can help the patients, and it really looks wonderful. When somebody else tries to do a triple upfront combination, it could look very dangerous. And that's why I warn providers who are giving medications to patients with pulmonary hypertension. Sometimes they have so many side effects, and it's hard to figure out, is that worsening heart failure, or is it a side effect of the medication? Is the edema from heart failure? So you really need the experience and the understanding to try and give patients a triple therapy. Again, the data is lacking. We do have the Triton study that will be published hopefully in the second quarter of this year, which will answer the question about upfront triple combination. But remember, intuitive sense in medicine is not always correct. So I gave some examples here. The very first FlowLand study that was ever done was used for actually systolic heart failure and had to be terminated early because we were patients on the FlowLand were dying. And then the same thing with the CAR study with flecainide with post-arrhythmia. It made a lot of sense. Clinically, it made a lot of sense, yet we were killing people. So just remember, you need to have clinical studies to be able to answer these questions. And then the other important part of this are the patient-centered considerations: severity of illness, risk of disease progression, adherence to therapy, where you're giving someone 3 therapies. Some are daily BID, TID dosing, and trying to get a patient to be compliant with that can be a real challenge. So patient preference is important. The cost of a triple therapy, is going to be expensive, and we just don't have the necessary data. I love my PhD, man. They must be right. So we'll keep throwing up with all these meds, and patients will often go to the end of the world to be, to sort of please us. But remember, they're living this disease. And then I talk about the nurse-centered considerations. We're some of the nurses who have helped me with PH over the years. You'll recognize this. Yeah, we're going to be short-staffed forever. So if you could just work yourself to death, that would be great. And this is my nurse coordinator with the paperwork that you would need to get triple therapy arranged. So for the last 3 minutes that I have available before everyone gets to their margaritas and develop the atrial fibrillation, I thought I would briefly talk about some of the new novel target therapies that are out there. And these are very exciting therapies because it's now branching out of those 3 groups that we have always traditionally looked at. And it's to look at some of the newer things. So for example, I've just listed some of the clinical trials that we have available here at our center that are looking at some of the pathways. So rodostratat is a 5-HT inducer, and it works through the serotonin pathway, so as a vasoactive mediator. We're looking to see if that is going to have an impact on the vessels. Bardoxolone methyl, this is a very interesting compound looking at inflammation within the vessels. and it's not a vasodilator, so, but we are looking at it specifically in our scleroderma group of population as a way to try and actually alter some of the genetics, the gene parts of the BMP2R mutation. A newer study looking at some inhaled tyrosine or PDGFR kinase inhibitors, which have been shown to be immune modulation of the endothelial cells to try and prevent the apoptosis that occurs, the lack of apoptosis that occurs in the pulmonary vasculature. There is an older compound, vasoactive intestinal peptide, that has been tried a number of years ago in pulmonary hypertension. It didn't really work because I think that we had a very poor delivery in terms of how we've done it, and now they've devised a new subcutaneous sustained release VIP analog that we're going to be studying here, again, of another vasoactive mediator. And then some of the newer therapies, such as the ralinepag, looking at a newer IP receptor, longer acting effect on the IP receptors, and then looking at various different combinations and higher doses of those traditional pathways. These are all available here in Santa Barbara. And then looking at branching out from the group 1 disease, such as to the group 3 disease, which was, for example, the inhaled treprostinil for COPD and pulmonary hypertension. So with that, I'm going to just quickly brief summary. We have improved overall survival with pulmonary hypertension, but annual mortality remains high. And we have a long way to go to really understand and improve the lives of patients with pulmonary hypertension. If there's one message I can take that you should take from this meeting is that if patients are on therapy, you really need to reevaluate them and reassess them on a very regular basis to determine that they are meeting their treatment goals, and the goals be to get them into the low-risk categories. The rationale for sequential and upfront dual combination therapy, I've provided to you with some data from the AMBITION study. We are anticipating getting the data from the TRITON study, which will look at upfront triple combination therapy. High-risk patients should and must include parenteral prostacyclin therapy before you can consider it a treatment failure. And remember, patient satisfaction and quality of life are still poor, and adding therapies has not consistently shown improvement in all of these domains. So with that, I'll leave it there, and I'll take any questions.
Thank you. Dr. Aragon, looks like you have a question.
So, great talk. I just want to thank you for coming and sharing this with us, and I would like to congratulate you on just an amazing program that you've put together here in Santa Barbara. And I think we're very lucky to have someone like you in our community to provide this service.
Thanks, Joe.
Where do you see that you are getting the most of your patients coming from? I mean, from distance, how many are just in our community? Where do your patients come from?
So it's various. One of the things that we have done is we have obviously had a lot of outreach to Bakersfield, the communities in Kern County, up north and south, and because we have access and we provide clinical trials, we have patients coming. I have patients from Las Vegas coming to get enrolled in clinical trials. We have patients from Thousand Oaks who'd rather it's easier to them to travel up north than it is to go down south. So the catchment that we pull is from a wide net. The referrals come from so many various sources. Cardiologists looking at echocardiograms. We have a very robust rheumatology department. Sansom Rheumatology are very attuned to scleroderma patients with pulmonary hypertension. So we do see a number of those. So I think the biggest area is awareness, is getting out there, and because we've done that, we've gotten from pretty much the Central Coast.
Jeff, getting back to the most important organ of the body, the heart, you sort of glossed over the use of ACE inhibitors and beta blockers and such. Do any of those therapies that traditionally help left heart failure help the patients in terms of survival or anything else when you try to treat the right heart failure?
Are you asking this as a cardiologist or as an administrator?
As a cardiologist.
Oh, okay, just checking. That's a great question, Ed. It's actually been looked at. We've looked at ACE inhibitors for pulmonary hypertension when one of the first times it was looked at. And unfortunately, it does not have an impact and an effect. There have been studies looking at there was a blood at the beta blockers, because traditionally the beta blockers have always been a no-no for pulmonary hypertension because we're concerned about dropping the blood pressure and causing issues. More recently, however, the Swedish published data showing that the low-dose beta blockers and the tempering down of the sympathetic tone actually could be helpful in patients with pulmonary hypertension. So in those patients that have significant right heart dysfunction, with irritability of the right ventricle and frequent episodes of them going into SVT or arrhythmias, we will often use a low-dose beta blocker. The problem is we don't often have a systemic blood pressure high enough for us to be able to use those agents. So in fact, when I have a patient who has systemic hypertension and their systemic blood pressures are high, I question the diagnosis of PH because is there something else? Is it heart failure with preserved ejection fraction, or is it a shunt or something else that we're missing? But yeah, and yes, the right ventricle is more important than the left ventricle.
Can you determine Can you determine on an individual patient which of the three pathways is the most important to target, endothelial nitric oxide or prostacyclin?
Thanks, Larry. Haven't seen you in a while. Good question. So that's a really good question, because what you're getting to is something that let me see if I can find on my backup slides here, is what we call targeted. This is actually an abstract that was from Dr. Ray Benz's lab. The answer is we are trying to find that answer, because just like we do for lung cancer now, we have certain gene profiles that we know will respond to certain therapies. So we know that there are certain polymorphisms, for example, that affect endothelin receptors that would make patients more susceptible. So this is just data. This was from, one of them was from Stu Rich and the other was from Ray Benz's lab, where they looked at certain genotypes that showed that patients who had the genotype TT were much more likely to be responsive to an endothelin receptor blocker than, for example, to nitric oxide. We haven't gotten all of the information about which one we should use. There have been some clinical trials looking at gender and race. So, for example, we know that males and African Americans tend to have a higher response to endothelin receptors than the nitric oxide pathway drugs. But the future of where we're going with this is to be able to do some sort of gene array, looking at who is going to be more susceptible. Right at the moment, we shoot from the hip, and we don't really have a good answer to which ones will respond and which ones don't. And that brings me to my point about that if patients are put on therapy and they don't respond within 3 months, you need to be reevaluating that so that you can make a change or add to their therapy.
Great. Any final questions? I think we'll turn it over to Dr. Aragon for a closure here. Dr. Sager, thank you for